I'd like to thank all of our speakers for all those important insights. Very helpful to us. We will now go to our FDA panelists to see if they have questions for any of our session 1 speakers. So I believe Dr. Youngwook Choi has the first question.
Thank you. My name is Youngwook Choi, a bioinformatics reviewer in OTP. I have a clarifying question for Nancy Myers. So one of the bullet points in your slides mentioned reducing the number of off-target assays. So for example, in CRISPR-Cas9 system, are you referring to leveraging off-target data across different guide RNAs that target different genomic loci, or leveraging data for the same guide RNA across different products?
I think it could be done several different ways. I think where I was focused the most was on LNPs, and kind of thinking that if you've had experience already and you've started, your data shows that there are many off targets that are unnecessary, then it would then be where you could try to start focusing the types of information that you have to collect. I think that throwing open the doors and looking at everything all the time probably is not the most efficient approach. So I think that's where I was headed.
Okay, thank you.
So thanks.
Great, thank you very much for the question. So our next question is going to come from Dr. Emily Wires.
Hi, my name is Emily Wires. I am a farm tax reviewer. We actually have 2 clarifying questions for Nicholas Buss. The first is, could you please clarify if your proposal is that the reduction and elimination of the interim necropsy time points would be based on pilot non-clinical studies with the intended clinical product, or leverage from products in the same class administered via the same route of administration?
Yeah, no, thank you. It's a good question. I think it's a combination of both. So, for example, if you have pilot tox studies where you have duration is say 4 weeks, then that data can support the GLP tox study if it's being sufficiently run to appropriate standards. I think if you do not, for example, have the pilot tox or the dose range finding, I think there may be occasions where you can omit an interim necropsy based on the endpoints you include in your study to monitor for known AAV-mediated toxicities, for example. And the example I gave is, for example, if you are injecting into the eye, you have a whole plethora of imaging endpoints that you can use, OCT, ERG, ophthalmoscopy, which is probably a more robust longitudinal assessment of ocular toxicity than having the need perhaps to do a necropsy at 4 weeks.
Okay, great, thank you. And then another question. So regarding the justification, what would be needed to justify the use of rodents to inform the dosing and safety of an AAV product?
Again, this is, as mentioned, it's very much case by case, and I think you would have to use platform data you have. For example, an experience with capsids. I think you have to look at the animal model, your indication, and I think the route of administration. And if, for example, and the fact that the rodent is a relevant species, then I feel like the rodent should suffice. Again, it's very case by case. I think if you're looking for it may be important to include a small non-human primate example study, for example, to offer supporting data to help bridge between rat, monkey, and human. But then if that data is available, say on another project with a capsid, similar promoter, for example, then I would imagine that could be used as well.
Okay, great, thank you. We actually have one more question for Pushpenda, Singh from Ocugen. So could Ocugen give an example of what justification would be needed to minimize bridging non-clinical animal studies and what kind of bridging data would be needed?
Yeah, I think, thank you for the question. So I think for the non-clinical data and the bridging of the non-clinical data, let's say if we are going with the similar indications, let's say the indications are in the ocular and there are many, developing therapies are there. So one thing is that we are producing, let's say, multiple batch of the different gene therapies for 2 different indications. So in that case, if we are using the same manufacturing, I believe those whatever non-clinical studies have been conducted with the same dose of administration, so that they can be simply taken for the biodistribution as well as for the toxicity. So because the capsid serotype remains same, so and the manufacturing process remains same, so that can be directly utilized and leveraged to go forward for the IND submission. With that, you can do the risk assessment. So that's one. But I'm saying across globally also, let's say there are different sponsors are producing the data. So is there a mechanism that we can come up with that all those redundancies can be cut down? So you have somebody has done worst case scenario highest dose, and if you are going with the lower than that, can that be utilized even from the other sponsor? So that will be something path breaking, and that can really cut down the cost on that aspect.
Okay, great. Thank you.
Okay.
Great. Thanks so much. Okay, let's see if we have any more questions from our FDA panelists. It looks like we do not.
This is Katarina.
Oh. I hear someone speaking. Oh, Katarina. Great. Go ahead.
I have to our meeting for the great value for. I have a couple of one question for Dr. Mohanty from Nanoscope. I understand that you find it useful to share safety and efficacy data among different indications for your product. But since this product, since this optogenetic treatment is a category of its own, would you find interesting to leverage data among different products of the same category too?
Thank you for the question, but sorry, I could not hear it very well because of some audio issues. Can you please repeat the question, Dr.
Yes, of course. I am going to use my headphones. Okay. Can you hear me better now?
Yes, please.
Okay. So I understand you would like to leverage data among the safety and efficacy data for your product on different indications. But since your product is a separate category on its own of the genetic treatments, would you find it useful to also share data among products of the same category? So leverage data among products of the genetic treatment products as well.
Yes, not all optogenetic products are same. Our opsin is very broadband and highly sensitive and targeted to specific promoter, bipolar cells. So across indications in ocular space, I think the data can be leveraged. But in future, if this probe same opsin is used for neurological indications, for example, pain and other neurological conditions, then it should be leveraged that the expression of the opsin is not creating any immune response or things like that. So, but broad from an optogenetic category, I think all opsins are different. Our opsin come from 3 different non-mammalian proteins, is a fused protein. So I'm not sure if we can share data across different developers. But of course, I will say that neutralizing antibody baseline value, how it impacts the efficacy or safety to a AAV2 serotype, our data can be leveraged to other manufacturers.
Thank you very much.
Thank you.
Great. Thanks so much. I'm wondering, do we have any more questions from our FDA panelists? I'll give a couple of seconds to see if anyone has anything they want to ask. Okay, great. It looks like we do not have any more questions. So at this point, I'd like to thank our FDA panelists for and all our public speakers in session one for your preparation, your presentations and remarks. We're going to break for lunch, and we will resume the public meeting at 12:45 p.m. Eastern Time. If you are one of the public speakers in session two, we ask that you please return to the meeting at 12:30 p.m. Eastern Time. At that time, you will be given access to the microphone and camera. Thank you all again, and we'll be back at 12:45 p.m. Thank you.